This was the topic I was assigned, which is evidence-based medicine, which is always the funnest, most sexy topic imaginable. So thanks, Rich. I love you too. There's no statistics in this at all. I'll show you why. So there's a lot of things going on with evidence-based medicine. If you're not at least trying to practice in evidence-based fashion, you're doing it wrong. Okay, there's been a revolution that's been happening for decades. So if a slide has a red background like this, I'm going to be talking about specific studies and why that matters to you. Okay. So here's a few things that I think you should really change as an adult learner. Okay. There's this model that gets perpetuated, particularly in colleges, of I want you to read the primary source. Okay. Like you take a history class, they don't want you to just read a book someone else wrote. They want you to actually read the letter that Thomas Jefferson wrote or whatever. To be honest, the medical literature is too huge for you to do this beyond narrow niches that you really care about, are really important things that actually change your practice in a major way. I do not think that anybody in this room wants to read hundreds of articles a month. Okay, I try to do this and it is awful, and I don't recommend that anyone else try to do it. It really is terrible. Okay, so don't. So crowdsource. There are other nerds out there that are doing this. If they don't have conflicts of interest that mean that you shouldn't trust what they're saying, okay, you should most likely believe them if they don't have some reason to. Okay, if someone is getting money for a particular drug or something like that, and they say, hey, my drug is the best thing ever, you should appropriately pause and say, wait a minute. But if Ryan Radecki from EM Lead of Note says, hey, I read this paper on strokes, this is what I feel about it, well, he's not getting money either way based on whether he's for or against TPA. You should probably believe him because he truly is just doing this for educational value. So crowdsource it because there's nerds like me that are doing part of this work for you. But you have to pay attention to their conflicts of interest. Okay, if they're getting money from one side or the other, you have to at least acknowledge that. Now, it's very hard to get major trials published without some big pharma money because they've got more money than we do. Okay, and because of that, I wouldn't say that just because a pharmaceutical company sponsored a trial showing their drug works that you should completely ignore it. You just have to take that into account. Okay, but be cautious. There's a lot of traps involved with overinterpretation of papers. There's a lot of things where we look back 10 years later and say, wow, we were really idiots back then. We'll never make that mistake again. And what do? We make those mistakes all over again. So stay humble in everything that you do. Okay, and use multiple sources. Okay, don't get all your information from one place. Okay, if you're reading just one blog or just one journal or something like that, you're going to miss a lot of stuff. So spread it as far and wide as possible. So here's how I approach a paper. The first step is, do I care? Okay, so if this paper proves the thing that they say that it proves, would I care one bit or the other? Okay, and you're going to see a lot of literature that falls in the I don't care pile. Okay, some of this is outside the scope of your practice. So exactly what should the fifth line agent be for hypertension and diabetics? Largely don't care. It's not really going to affect most of what I take care of. If you're interested, that's great, but this is not something that's going to change you on a shift-to-shift basis. Okay, your fifth line treatment for migraine headaches, pretty relevant. Your fifth line treatment for back pain, pretty relevant. But for something like that of just how do I get better diabetic control, probably not going to change what you're doing and I don't care. Or if it's so obvious that this is something that's going on that, well, again, I don't really care. So if someone published a study that said that drunk drivers crash their car more often, well, thanks, Sherlock. I didn't really need a paper to tell me that. I'm not going to take the time to read it. Unless there's something surprising about exactly the order of magnitude or something like that, I don't care. Second, is it good science? So if I cared about what they said, did they prove the thing that they said that they proved? Okay, and this is where a lot of EBM stuff actually gets into, of ripping apart the paper. Do we actually show the things that we wanted to talk about? And then the last part, and the part that gets neglected often, is even if I care about the topic, and even if their science was good, is this something that I should personally change myself? And this gets left out a lot, where young firebrands, they go out there and say, yes, this is the thing that should happen. We should absolutely be discharging subsegmental PEs home with no therapy whatsoever to thin their blood, which is scientifically valid, but something that I would tell you not to do right now. Okay, I have not changed my practice because I don't feel like that is a good thing to do at the place that I worked. Make sense? So, question one, even if the study were true, do I care enough to change my practice? So I strongly encourage you to use electronic apps. If you're trying to use paper journals, it's murdering a bunch of trees for no apparent reason, and it just really clutters up your apartment. So don't do it. QXMD has an app called Read. Go ahead and download it if you haven't already. You can actually sign in using your institutional email here, and it actually gives you access to journals that aren't open access. Okay. A lot of the heavy hitters like New England Journal, et cetera, you actually have to have an institutional login, and you can actually set that up through that. Don't have time to do that. Pick a few key journals, okay? If you're only going to pick one, Annals of Emergency Medicine is the way to go, okay? That's our most important journal, but I would encourage you to at least skim the articles of major ones like New England Journal or JAMA, Lancet, BMJ, etc. Okay. There's also some other, they're not quite second tier, but some other emergency medicine journals that aren't quite Annals level that actually have some really incredible articles out there. Some of them actually like the editorial work better than Annals of Emergency Medicine. Don't have time to talk about it, but pick a few journals that you're actually going to skim from. Okay. And focus on randomized controlled trials. Okay. Just because it's published in a journal doesn't mean that it's necessarily all that great. It just means that someone sort of kind of peer reviewed it. If you've been part of the peer review process like me, at times you're going to be a little brokenhearted that it's not a little bit better. There are some very good studies that don't make it through peer review. There's some absolute crap that gets published. Okay, so focus on randomized controlled trials, because just because someone's editorializing in a journal doesn't mean that you should necessarily believe them any more than if they're editorializing in a newspaper. Okay, because the peer review process is not robust enough to weed out all the crap. So, what are some things that just mean I'm going to stop right now and completely ignore the rest of this paper? I've read like basically the title of it or something like that, and I'm out, okay? So if it's irrelevant, it doesn't impact my practice, okay? This is the 5th line hypertensive paper, for example. If the findings are obvious, such as people that hit their head are more likely to have head bleeds, thanks, I don't really need to read a paper to do this. If it's animal science or bench science, I largely ignore it. Now there's a few areas I want to put a caveat on that for, okay? Some things can't realistically be studied in humans. For example, some of the hemorrhage studies that are out there, there's been some very good research actually done in our department on pigs. It's because it's not usually okay for an IRB to say we're going to cut people open and cut their femoral artery or hit them with the sword or something. Like, you can't really do the study. And so a pig model actually makes a lot of sense for that. But whenever possible, you want to see this translated into human research as soon as you can, okay? Bench science is almost always wrong, okay? If you cure cancer in rats, congratulations. You've got a budding career as a rat oncologist, but it means nothing for the patient in front of me because it's not patient-oriented, okay? The other area that I would say you should actually pay attention to, even when it's not on patients, is toxicology. It's incredibly hard to do very good like cyanide research in human populations because a lot of the worst patients don't have time to be randomized into trials, okay? So if you're looking at new things and it's a big pig study or something like that and cyanide poisoning, it's totally okay to use that because it's unlikely that you're going to get superior data from humans. If it's impractical, okay, so say that you work in a community shop and they're talking about the use of Reboa, okay, you can't practically get that instituted at your hospital at this time. It might be a good idea to tap the brakes on that unless this is something that you think you could actually institute at the place you work. Right now, you're at a level 1 trauma center, okay? So what can be done is very high, okay? What might actually work at your institution is more difficult. So I'm real passionate about ECMO. There's a lot of logistical reasons why we don't have a more robust ECMO program here. And so I'm working on that. But if you're working at a smaller shop, that might be a little impractical for you to get done, okay? So an example of this is the STEMO study, which is basically that a bunch of Germans, they had an ambulance that they tricked out with a head CT. And it turns out that if you ride around looking for stroke patients, you can actually get the head CT done and you can push TPA in the back of an ambulance. This is problematic on multiple levels. First off, I think it's kind of awesome. But honestly, like all that they proved was that yes, we can push thrombolytics faster. Okay, and so it fails on multiple areas of yes, you did prove that you could push lytics quicker, but did patients get better? No, they didn't actually. But you did shave 20 minutes off, which was roughly the 20 minutes it took for you to be picked up by the ambulance crew and driven to a hospital, as opposed to literally having a head CT and then getting TPA before driving down the road at high speeds. Again, awesome, but it fails this as far as a study that you really shouldn't care about, okay? So how do you approach the paper once you say like, okay, I've read enough of this paper, usually from the abstract, to where I actually want to read more of it, okay? The main thing that you want to look at is the PICO, okay? So population, who was it that was being studied? And the way that I really want to focus on that is this the same people that you take care of, okay? So if you had a study that was based in Brazil, okay, and they were looking at pediatric intensive care patients in Brazil, are those kids sufficiently different from the same kids that you're taking care of to where it matters? And the answer really depends on exactly what you're looking at, okay? Sepsis is probably sepsis, okay? And that there's actually a Brazilian PICU study that is why dopamine is absolutely terrible and should never be used as a vasopressor. It is the single best study on why that is a murder drug for bad doctors, and you should never use dopamine. Can I emphasize enough how much I hate dopamine? But the study that it's being based on is septic kids in Brazil. Now, there might be differences between septic kids in Brazil and here, and that's totally fine. So as soon as someone can present me a paper that shows dopamine is a good idea in American kids, and that American kids are somehow different than Brazilian kids, I'm listening, okay? But it also applies as well for like chest pain studies. The chest pain folks that present to the primary care doctor are fundamentally different people than the chest pain folks that present to the emergency department. They're self-selecting themselves out. So make sure that when you're applying this, that you're preferably looking at emergency departments, and preferably they should look a lot like the department you work at. And so focus on those differences, and are they relevant, okay? Some things are just across the human spectrum similar. Some things really are different. Those Brazilian kids had a lot of the same illnesses that American kids have when they go into the PICU, okay? A lot of respiratory stuff, etc. And so it makes a lot of sense for me to say that they're the same, okay? It might not be the same that I should apply data from Africa, for example, that shows that normal saline kills kids with malaria, okay? It's scientifically proven that it does, okay? It's a really bad idea to be doing fluid boluses on septic kids with malaria in Africa. I don't know what that means for me in the emergency department when I see a kid with pneumonia that's septic. Do I give saline or not? And it's hard to say, okay? But see how that's different, that the respiratory kids in Brazil, very similar to what I admit to the PICU, versus those kids with malaria out in Kenya, actually different, even though those are both Southern Hemisphere kids. So then the intervention, right? So we've established who the people were. What is it that was being done in this study, okay? And can you do what they did, okay? So if they show that, yeah, we popped Reboa in these folks and got this outcome, can you pop Reboa in the same way that they did? If not, is this something that you'd like to try to do, okay? So there are promising drug trials, for example, that have drugs that you can't get on your local formulary, okay? Unless you're wanting to fight to get that drug, you probably don't want to read that paper because it's not ready for your local institution yet. Then comparison. So what did they compare it to, okay? Ideally, you should find out what the other group got. Now, there's a lot of junk science out there that basically puts straw man comparisons, right? So we gave this really expensive new antibiotic, and then the other group got essentially nothing, or they got subpar care, okay? I don't need a study that shows that ketamine gets better pain control than staring at your patient and giving them nothing, okay? That's too low of a threshold to actually prove, okay? I do like a paper that shows I gave this group ketamine and I gave this other group an appropriate dose of morphine, because that's a realistic option that I might have done otherwise, okay? So make sure that the other group was basically fair treatment, okay? There's a lot of really crap things that pharmaceutical companies will do to get their drug approved that basically shows that their drug is better than nothing, okay? That's not fair, because really it should be our drug is at least as good, if not superior, to what they would have gotten otherwise, okay? I have no need for a diabetes medicines that somehow lowers your blood sugar. I have a great need for diabetes medicines that do it better than metformin, okay? So make sure that the other comparison was actually reasonable as well as an appropriate dose, right? So was it ketamine versus 2 milligrams of morphine where they're getting these homeopathic doses that weren't good enough to do anything? Or did ketamine actually beat 10 milligrams of morphine, which is a really respectable dose to give? And then the outcome, and this is one of the ones I really want to stress. Was it clinically significant, okay? Everyone focuses on the numbers, okay? And again, this is EBM without any statistics. I'm not showing you any numbers. So I don't want to talk about p-values of 0.05 or anything like that. Was there a clinical difference that mattered, okay? Did this barely move the pain scale where it moved like 1 millimeter? Or was this like, oh, this was a huge change, right? They went from having 8 out of 10 pain to 2 out of 10 pain. Those are the things I want, okay? And it should be patient-oriented. It's way easier to do research that says I gave this group a drug and this group a drug and their blood pressure got better, or their sugar got lowered, or their length of stay was shorter, or something like that. Not all of those are necessarily patient-oriented. The length of stay is, okay? But exactly what your blood sugar is, I don't care, all right? I really don't. I only care about the things the patient cares about, which is to live longer, have a higher quality of life, etc., okay? So make sure that the thing that you're checking for is not something like, oh, does TXA reduce the amount of blood you have to be transfused? Well, I don't care, really. Does TXA reduce or does it increase the hemoglobin that you have after you give it? Again, I don't care. Does TXA save your life? Oh, I care, okay? So it really matters that this is actually a patient-oriented outcome. So, question 2, were the methods used sufficient to prove what the author said that they proved, okay? So if you do what is basically just read the results section of the paper, and I know that people have done this because I've done it myself, of you skim everything else in the abstract and you just go to the author's conclusion, and you just read that and it says something like, TXA saves lives in trauma patients. You're like, great, that sounds wonderful. Okay, and you didn't read any of that. Well, this is where you have to actually look at the different types of study and how it was structured, okay? So going from basically worst to first, you get your test tube animal data, okay? Mostly hot garbage, but remember, some of it is actually relevant, particularly toxicology, particularly hemorrhage control, okay? Then you've got editorial stuff where you kind of have someone that's basically just giving you their piece about what they think should be done, but it's really not great data. You've got case reports, okay? Larry Melick was a faculty member here, and he actually really stressed how important case reports were to generate other hypotheses. So if something goofy happens in the ED and you're like, this is a really weird case, you should probably write it up as a case report. It's a good way to get published, and it furthers science. Because if a bunch of other people notice this goofy thing where someone had bleeding from their ear or something like that after you gave them amoxicillin, there might be something going on, okay? So instead of just saying like, that was weird and then moving on, get some extra information, publish it, see if other people have seen this. Then you've got case control studies as well as cohort studies. We'll talk a little bit more about those in just a second, okay? Randomized controlled trials, which are my favorite type of study, and then meta-analyses, which are basically taking extra bits of details from those others and compiling them together, okay? We'll talk about some of the benefits of that in a minute. So case control, what exactly is this, okay? You begin with the outcome, okay? So, for example, people with lung cancer were more likely to be smokers, okay? Your study was based on the idea that at first we went out there, we found a bunch of people with lung cancer, and then we looked back to see, hey, did you smoke? Okay. To do this properly, you'd have to find a bunch of people that also didn't have lung cancer and then find out how many of those people smoked. Make sense? Okay. So if we were just real practically saying like who did well in the in-training exam, okay? So we identify, 6 residents with really stupid high scores on the in-training exam, okay? Then we look back and say, hey, what is it that they did to prepare? Did they do a bunch of question and answers? Did they use HIPPO? What is it that they used? We'd also have to take several people that didn't do well in the in-training exam and look back at what they did. Okay, and we basically informally did this and find out if you're just doing questions and answers, you're going to get a low in training score. Okay, so you need to do something more to prepare, right? So that's how this kind of case would be done. Versus a cohort study, which is a little bit better data. This is prospective and observational. This is basically we say, okay, I think smoking causes lung cancer. Let's watch a bunch of smokers and then see if they get cancer later on. This is a little bit more robust because you're looking forward in time as opposed to potentially data dredging with the other method. Okay, you're going forward and watch. Now, the problem with this is it takes time, okay? Because as opposed to the lung cancer folks we know have lung cancer, it's very easy to ask, did you smoke 10 years ago? It's much harder to take the time of, yes, we're going to watch this group for 10, 20 years, watching them slowly die of lung cancer to collect our data, okay? But this is a little bit of a superior type of study. They can't establish causation. They just establish correlation, okay? So post hoc ergo propter hoc, I'm not going to go into Latin. That's way too early in the morning for that. But just because things are associated doesn't mean it's causative, okay? There could be other things going on, okay? It used to be, for example, coffee was associated with lung cancer, okay? Coffee actually reduces your mortality. We know this from actually good science. But why was it that coffee was associated with lung cancer? It's because the people that drank the most coffee were also smokers because they were smoking more. And so they were drinking more coffee, okay? Because of that, it would make it look like coffee causes lung cancer. And if you just stop there, you'd say, oh, there it is. Clearly coffee is bad for your lungs. It's not, actually. It's that other thing that was going on. Because smokers and non-smokers are different in other ways, okay? Smokers are more likely to be poor. They're more likely to be less educated. There's other things going on there, okay? So this makes a correlation possible, okay? But it doesn't necessarily actually prove it, okay? So you could do similar things such as the murder rate goes up during the summer, okay? It does. For some reason, when it gets hot, people feel like shooting each other, okay? Ice cream sales go up in the summer, okay? But it's not like people are eating Ben and Jerry's and going on a murderous rampage, okay? The opioid epidemic is killing lots of people. Taylor Swift is very popular right now. I don't think, but can't prove, that Taylor Swift is not killing millions of people every year. I think she might. But you can't prove that. You can just show that they're associated together, okay? So the best evidence in emergency medicine is a great checklist that you can actually use for randomized controlled trials. I'm not going to belabor every one of those points. If you follow the SGM podcast, which I strongly encourage everyone to download a random episode of that just to try it out, they'll actually go through these checklists on different trials, and you can actually see how this works in practice. So, reviewing the PICO, when you're looking at a randomized controlled trial, okay, you want to make sure that it's truly random. And so how did they randomize, okay? And did they conceal that randomization? There's a lot of studies that use things like envelopes that make a lot of sense to the non-trained person. Is like, oh, envelopes got to work. But if your envelopes aren't perfectly opaque, people will actually cheat. And they found this again and again with like paramedics doing these studies in pre-hospital environments, and they give them these envelopes. And they're like, I really think this drug works for someone. They'll like look at the light and like try to look through it, and they'll try to cheat. And we can actually numerically prove that they do this. So how effectively did you conceal how you randomize them? Because otherwise you'll end up with these weird cases of like 10 patients in a row didn't get it because they knew that it was a placebo envelope because the paramedics cared about the patient. Okay, so make sure that they're properly concealing it. And this should be reflected in the fact the group should be similar. Okay, so if we just split everybody in this group, okay, right down the middle, okay, there might be problems with how I randomized it. Okay, if I got 70% of the women in one group and only 30% of the women in the other group, okay, there could be a problem with how I randomized it. Now, some of it will just be statistical noise, and that's fine, but they should be roughly evenly distributed if you have a large number. So be wary of any study that's got major differences where one group is like 10 years older than the other group. Something went wrong during the randomization process for that to happen. Okay, so NINS 2 actually had a big problem with this. Okay, this is the major trial that actually got TPA for stroke established. Through no fault of their own, the group that got TPA was way healthier than the group that got placebo. And so it actually made it look like the outcomes that were worse for the folks that got placebo was because they didn't get TPA. In actuality, the people that got placebo had worse strokes. Now, I can't tell any actual evidence of chicanery that happened during this study at all, but it is the case that they were significantly worse when they started. And the number one determinant of how you do with your stroke is how sick were you when you presented. Okay, if you have a massive stroke, it doesn't matter how good your care is, it's going to be tough. If you had a very minor stroke, you're going to have universally good outcomes because your deficits were never that bad to begin with. And so that's what happened in NINS 2. IST3 started off as a blinded randomized controlled trial, then became an unblinded trial that was no longer an RCT, okay, because it was unblinded, okay. So when they took away the blinding, they basically ruined their study. The part that was blinded actually had a strong trend that was nearly statistically significant to show that TPA actually caused worse stroke outcomes. And then when they unblinded it, it turns out the outcomes got a lot better for the TPA group. So, selection bias. So that very thing that I told you the paramedics were doing, where they actually chose which group got what, look for consecutive recruitment, meaning that we saw 20 patients and all 20 got randomized into our trial is awesome, okay? Because otherwise you might be cherry picking the cases that you think are most effective for your intervention, okay? This was another issue with IST3. They had intermittent selection and very odd requirements to be selected. To get into this trial, you actually had to state by your physician that you thought they would benefit from TPA. They actually selected people that would actually believe that they would benefit from it, because if they didn't, then they wouldn't be randomized into the trial. So make sure that it's properly blinded. And you want to blind as many people as you can. You definitely want to blind the patient, okay? Preferably blind the provider as well, meaning that nobody knows whether you're getting placebo or whatever the comparator is versus the intervention. Ideally, you would also get the assessor as well. So if someone later on was going to come along and say like, hey, how did your patient do? You'd prefer to have that person blinded as well as to what actually happened to them. And make sure that you had an adequate placebo. So, for example, if you have a drug that has a distinctive taste or there's other signs that you know that you got it, your placebo ideally would actually be an active placebo, meaning that they would not be able to tell that it's something different. This is one of the things that we're running into. We're looking at trials that have nausea being controlled by smelling alcohol swabs. Well, that's difficult to actually make a good placebo for because the smelling of the alcohol swab is going to be different than smelling a saline swab. You could actually detect that there was something on it. So is it truly that it's alcohol in particular, or is it just anything smelly that's put under your nose? We don't know yet because they haven't done an active placebo trial yet. So if your trial is unblinded, such as IST3, take it with a grain of salt. And then make sure that you got adequate follow-up. So the thing I care the most about is long-term patient-oriented outcomes, okay? So if you stop early, you actually have problems with that, where you don't end up seeing exactly how far out, okay? I don't really care about how your chest pain does just for the next 12 hours, because most people won't die in 12 hours. I would really like to know how far out they followed. So a meta-analysis is basically just taking a bunch of studies together and seeing what you get. The problem is you end up with garbage in, garbage out scenarios, where if you've got crap studies that you pile together, you just have a big pile of crap as opposed to actually something that's better. Okay, this isn't alchemy. It's not going to turn your crap studies into gold. It basically is just going to compile them to give you a better idea. A systematic review is basically just a global literature search. Okay, you may not be able to get a meta-analysis if the studies were too different. If they use wildly different selections, for example, you can't combine them in a statistically meaningful way. Okay, so you might just see what's called a systematic review. That's what most of the people in this room are actually going to be involved in the next year, of taking a topic and seeing how that works out. So I won't belabor that more. But you have to have similar studies, okay? And were these things enough to actually change my practice, okay? So why is it that I might or might not change it? Well, you have to think of the prior science. So just because one trial showed one thing, you really have to think about what's going on all the other prior studies, okay? So if I told you that there were half a dozen studies before IST3 that had negative outcomes for TPA or similar thrombolytics and stroke, then you should probably be like, well, why did this one study change my practice, okay? You should also look at the strength of results. Did it just barely achieve significance where it just eked across the finish line? Or was this a very robust proof that it actually worked? How good was the research done? Was it a good quality paper? And is it applicable to where I work? So statistical significance versus clinical significance is very important. So if I could take enough patients and had 100,000 patients and I all gave them the same medicine and I lowered their blood pressure by 1 millimeter of mercury, right? It could be statistically significant because I have this huge study, but it doesn't matter at all to patient outcomes at all, right? It's just 1 millimeter of mercury decrease in your blood pressure. It doesn't matter a bit, but it was statistically significant, okay? Versus another medicine that might drop your blood pressure by 40 points, right? That would actually be clinically significant. That's a big change, right? So you have to actually focus on what matters to the patient, and is this enough to actually change your process? So focus on the patient-oriented outcomes. So this is the whole pose versus dose. You got patient-oriented evidence, right? And you got disease-oriented outcomes, right? And always have pose before dose. Or choose long-term patient outcomes over ease of use in the hospital, and I'll just let this slide speak for itself. You really want to focus on actually stat jokes. You really want to focus on what actually matters to the patient, okay? Do not get lost, okay, in all the statistical rigmarole of, oh, look at the numbers and we played the game. Don't do that. Focus on, does this matter to my patient, okay? If I was that patient, would I care that my hemoglobin was 7.9 versus 8.1? Or would I care about, did I live or die? And make sure that the study's actually addressing the same stuff, right? So watch out for a few traps, okay? If the study changed its primary outcome, that might not be presented in the paper. And this is uncomfortably common, okay? Where there's a study that's actually looking at one thing, okay, and then they say, well, we didn't actually achieve that, but if we change what we said we were studying, we're good to go. This actually happened in NINS 2, where they changed what they were actually studying as a primary outcome, which went from being a negative study to being a positive study because they changed it after the fact. Not allowed to do that. Composite endpoints are a trap, okay? They'll have things such as MACE, which is major adverse cardiac events. That's where you're looking at heart attacks, mortality, and admissions to the hospital or something like that, okay? And these are not all the same things. I'm pretty comfortable with getting admitted to the hospital. I don't really want to be that way. I definitely don't want to die, okay? So you could actually have equivalents of the groups and it just be like unplanned cath lab trips, okay? Generated one group versus the other group died, okay? And it would be statistically similar because of the composite endpoints. And then industry bias as well. So beware of the fact that like, who's paying for all this, okay? So industry funding has always been a problem for quite a few of these trials, okay? Who's familiar with Pascal's wager? Yeah, all right, philosophy geeks, good. So Pascal wager basically stated that whether you should believe in God, you should think about what the outcomes are, okay? If you believe in God and you spend your entire life believing in God, and there is a God, you get to go to heaven forever, okay? If you believe in God and there's not a God, you basically wasted a Sunday every week, okay? Which wasn't so bad, right? If you don't believe in God and there's no God, well, you saved your Sunday every week, okay? If you don't believe in God and there is a God, you have eternal damnation, okay? Therefore, Pascal said, you should believe in God because looking at the odds, like, you're wrong in the right way, okay? Now, another theologian said that his God would happily send Pascal to hell for believing this, so don't think this is a path to salvation. But when in doubt, don't change. I want you to be pessimistic about the literature, okay? if you're going to be wrong in a conservative way. Unless the literature is really good, don't change what you're doing, because there's case after case where we screwed this up, we changed early, and we made some patient harm happen because of it. Okay? So that's my email address.